7 or 7:30. That's the hospital starts 7. The door is closed. We cannot enter anymore beyond 7. So before, there was discipline that our instructor was giving us. So we cannot enter the room anymore. It's big beyond 7. So this morning I'll be discussing the diseases of the adrenal glands. So the adrenal gland is a triangular shaped organ that is located on top of the kidneys. So it's a triangular shaped organ that is located above the kidneys. And the normal weight of the adrenal gland is about 6 to 11 grams each. But during stress condition, this gland increases in size and the adrenal output also increases. So during stress, the adrenal hypertrophies and the adrenal output increases. So the adrenal gland is divided into the adrenal cortex and the adrenal medulla. So the adrenal cortex produces straight process of corticotropic hormones, and there are 3 layers or 3 zones of the adrenal cortex. So one is the zona glomerulosa, the outer layer, which produces your aldosterone. The inner layer or the middle layer is the zona fasciculata, which produces your glucocorticoids. And the zona reticularis, the middle or the innermost layer, produces the sex hormones. This is the zona reticularis. And the adrenal medulla produces your epinephrine. So the disorders of the thyroid, of the adrenal cortex are characterized by either a hormone deficiency or hormone excess. So the production of glucocorticoids and adrenal androgens is under the control of the hypothalamo-pituitary adrenal axis. So the synthesis of your glucocorticoids is under the inhibitory feedback controlled by the hypothalamic and the pituitary. So your ECT or your CRH is released the hypothalamus is released in response to endogenous and exogenous stress. So your CRH regulates the production of your ECTH in the anterior pituitary. And your ECTH also regulates the production of your cortisol in the adrenals. So there are several diagnostic tests assessing the hypothalamo-pituitary axis. One is this is regulated by a negative feedback. So the first test is for glucocorticoid excess. So the test for glucocorticoid excess is a dexamethasone suppression test. The dexamethasone is a potent synthetic glucocorticoid which suppresses your CRH and ECTH by binding hypothalamic pituitary glucocorticoid receptors, resulting in downregulation of your endogenous cortisol synthesis. So if cortisol production is autonomous, meaning it's the adrenal gland that is producing cortisol by an adrenal nodule, so ECTH is already suppressed in this case, so your dexamethasone has little or has no additional effect. Another test is assessing glucocorticoid deficiency. And this test is your ECTH stimulation of cortisol production. So this test is your ECTH stimulation test. So for deficiency, it should be stimulation. But for excess, it should be suppression. So for deficiency, we need to use the ECTH stimulation test. We need to administer a cosintropine. Cosintropine is a synthetic ECTH, which is given at a dose of 0.25 milligram, given IM or IV. Blood is collected before you inject ECTH at 0. Then after injection, 30 minutes after injection, cosintropine, and 60 minutes after injection for cortisol. You need to get the serum cortisol 30 minutes and 60 minutes after injection of your ECTH. The normal response would be, if you inject ECTH, the normal response would be an increase in the cortisol production by more than 20 microgram per DL or 550 nanomole per liter 30 minutes after injection of cosintropine. So another test to assess glucocorticoid deficiency is your insulin tolerance test. Insulin tolerance would assess the adrenal function, and this involves injection of insulin to induce hypoglycemia. And hypoglycemia is a strong signal that would trigger the release of your hypothalamic corticotropin hormones, and this would activate also the entire hypothalamo-pituitary axis. So an injection of 0.1 unit per kilogram IV is given. Regular insulin is injected 0.1 units per kilogram. So if your patient is weighing 50 kilograms, then you need to inject 5 units of regular insulin. So collection of blood is also done before you inject at 0, then 30 minutes, 60 minutes, and 120 minutes for glucose. You need to get the glucose. You need to get the cortisol and growth hormone after injection. 30 minutes, 60 minutes, and 20 minutes, 120 minutes after injection of your regular insulin. The goal is to put the patient to hypoglycemic level of 40 milligram per DL glucose. So you need to bring down the glucose to 40 milligram per DL. So the normal response would also be an increase in the cortisol level by more than 20 microgram per DL and a growth hormone increase of more than 5.1 microgram per liter. But this test should be avoided in patients with coronary artery disease because this can trigger heart attack. If you render the patient hypoglycemic, this can precipitate also stroke. And in patients with seizure disorder, this should be avoided. So this can trigger seizure disorder if you bring down the blood glucose to 40 milligram per day. So the regulation, mineralocorticoid production is also under the control of the renin-angiotensin-aldosterone system. So this is initiated by the release of your renin in the juxtaglomerular cells of the kidney, and the release of the renin would cause cleavage of your angiotensinogen, and this will lead to the production of your angiotensin 1. With ACE converting enzyme, this would also help the cleavage of your angiotensinogen to angiotensin 2, resulting in the activation of your angiotensin 2 receptor type 1. Activation of the angiotensin 2 receptor type 1 would lead to the release of your aldosterone in the adrenals, and this would cause vasoconstriction and increase in the renal perfusion pressure. With the release of your aldosterone in the adrenals, This would also trigger or enhance the sodium reabsorption and potassium excretion, leading to an increased circulatory volume and then increasing renal perfusion pressure, leading also to the release, and the cycle continues. So the release of your aldosterone in the adrenals would cause vasoconstriction and increasing the renal artery perfusion, leading to the release of your renin in the juxtaglomerular cells of the kidney. So let's talk about adrenal insufficiency. So your adrenal insufficiency can be primary. So when it's primary, it's the adrenal that is affected. If it is secondary, it is the pituitary that is affected. Tertiary, if it is the hypothalamus that is affected. So primary, it should be the adrenal. So primary adrenal insufficiency. So your hormonal deficiency can be caused by an inherited glandular or enzymatic disorder, or it can be due to the destruction of the pituitary or adrenal gland by either an autoimmune disorder, which is the most common cause of primary adrenal insufficiency, autoimmune disorder. It could be due to infection, or it can be due to infarction of the pituitary, or it can be a iatrogenic events caused by surgery of the pituitary, and or hormonal suppression. So these are the causes of your hormonal deficiency. Adrenal insufficiency, I mean. So your primary adrenal insufficiency, it is said that approximately 1/2 of cases are acquired caused by autoimmune destruction of the adrenal glands. And 1/2 are caused by genetic disorders, most commonly by distinct enzymatic blocks in the adrenal steroid production affecting glucocorticoid synthesis. Your secondary adrenal insufficiency is a consequence of dysfunction of the hypothalamic pituitary component of the hypothalamo-pituitary axis. So these are the causes. I cannot see. So, but I want you to look at your horizon. These are the causes of your adrenal or primary adrenal insufficiency. So causes of primary adrenal insufficiency, I just want to summarize this one. So autoimmune adrenalitis, this is the most common cause of primary adrenal insufficiency. Your isolated autoimmune adrenalitis accounts for about 30 to 40% of cases, while 60 to 70% of cases may be due to autoimmune polyglandular syndrome, or your APAS. APS1 is transmitted as autosomal recessive manner. Your APS2 or your autoimmune adrenalitis is a polygenic inheritance. So these are the, cannot see. So these are the causes of secondary adrenal insufficiency. It can be pituitary, or it can be due to hypothalamic tumors, or can be due to treatment by surgery or irritation. These are the most common causes of secondary adrenal insufficiency in most cases. So these are the clinical manifestations of adrenal insufficiency. In primary adrenal insufficiency, remember that the affected is the adrenal, primary adrenal, the adrenal gland. So the patient may have manifestations of glucocorticoid and mineralocorticoid deficiency. So what are the manifestations? The patient may experience fatigability, lack of energy, weight loss, anorexia. Some patients may have myalgia. Some patients may have joint pains, fever, And if the patient has mineralocorticoid deficiency, the patient may experience abdominal pain, vomiting, dizziness. And patients may have postural hypotension. You let the patient, you check. When you are suspecting patients having adrenal insufficiency, you need to check the blood pressure in supine and sitting position. A difference of 20 millimeters mercury from supine to sitting position would suggest that your patient is having orthostatic hypotension. This is a common manifestation of patients with primary adrenal insufficiency. So signs and symptoms caused by adrenal angiogenesis may be lack of energy, dryness of the skin or itchiness of the skin, loss of libido in women, and loss of axillary hair and pubic hair in women. So other signs and symptoms may include hyperpigmentation in primary adrenal. This is seen in patients with primary adrenal insufficiency because due to the excess pro-propiomelanocortin derived peptides. Some patients may also have the alabaster colored pale skin. This is seen in patients with secondary adrenal insufficiency due to the deficiency of your propiomelanocortin derived peptides. So again, the clinical manifestation for chronic adrenal insufficiency, patients may manifest with relatively non-specific signs and symptoms such as fatigability, loss of energy, and sometimes patients may have depression and anorexia. So the biochemical features of patients with adrenal insufficiency, hyponatremia. This is a common biochemical feature, a characteristic biochemical feature in primary adrenal insufficiency seen in 80% of cases. This is caused by mineralocorticoid deficiency and can also be a feature of secondary adrenal insufficiency due to diminished inhibition of your antidiuretic hormone release by cortisol, resulting in mild syndrome of inadequate antidiuretic hormone secretion. So hyperkalemia can be seen in 40% of cases at initial diagnosis in patients with adrenal insufficiency. So what is acute adrenal insufficiency? This is also termed as adrenal crisis, usually occur after a prolonged period of non-specific complaints and frequently observed in patients with primary adrenal insufficiency due to loss of both glucocorticoid and mineralocorticoid secretion. So acute adrenal crisis or insufficiency can be triggered by intercurrent illness, it can be triggered by surgery or other stress, and by increased glucocorticoid inactivation, such as in patients with hyperthyroidism. So the manifestation of adrenal insufficiency would include, acute adrenal insufficiency would include postural hypotension, which may progress to hypovolemic shock. And some patients may mimic features of acute abdomen with abdominal tenderness, nausea, vomiting, and fever. Some may have neurologic disease or may resemble neurologic disease with decreased responsiveness progressing to stupor and coma. So the diagnosis of suspected adrenal insufficiency. So if you have a high index of suspicion that this is adrenal insufficiency, then you need to work up the patient. You need to do an ECTA stimulation test to check whether you're dealing with a primary or a secondary adrenal insufficiency. Do an ECTA stimulation test. So if there is an increase by giving ECTH or casintropine. So in patients with adrenal insufficiency, you stimulate by giving ECTH at a dose of 0.25 milligram IV or PM. So again, as I've said, the normal response would be an increase in the cortisol level by more than 20 nanogram per ml. However, if there is no increase in the cortisol level after injection of cosentypine, then you are sure that you're dealing with adrenal insufficiency. Okay? No response, no increase in the cortisol level after injection, then you're sure that you're dealing with adrenal insufficiency. So how do you treat acute adrenal insufficiency? You just rehydrate the patient by giving saline infusion at a rate of 1 liter per hour with cardiac monitoring, because some patients may have or you may give over rehydration or overhydration, and the patient can lead to pulmonary edema. So you need also to give glucocorticoid replacement. This is initiated by injection of 100 milligram hydrocortisone, followed by 200 milligram hydrocortisone over 24 hours, preferably by bolus or IV or IM injection. In primary adrenal insufficiency, you need to give mineralocorticoid replacement, and this can be initiated once your hydrocortisone dose has been reduced to less than 50 milligram, because the higher the doses of hydrocortisone, it provides sufficient stimulation of the mineralocorticoid receptor. So when glucocorticoid is given at a high dose, it has a mineralocorticoid property. So the patient can, it would lead to sodium and water retention. So at a high dose, when glucocorticoid is given at a high dose, it has a mineralocorticoid property. So the patient can go into pulmonary edema and through fluid retention. So this is the treatment of chronic adrenal insufficiency. You need also to give glucocorticoid, mineralocorticoid, and adrenal androgen replacement. So hormone excess is usually the result of, so let's now go into hormone excess. There are three conditions, adrenal conditions associated with hormone excess. One is your Cushing syndrome, the other one is your primary hyperaldosteronism, and the third is your pheochromocytoma. So it can be due to neoplasia, leading to increased production of your ECTH by the pituitary or neuroendocrine cells, or from ectopic ECTH production. Or it can be due to increased production of glucocorticoids or mineralocorticoids or adrenal androgen precursors by the adrenal nodules. The adrenal nodules is increasingly identified nowadays. These are discovered incidentally during abdominal imaging performed for other reasons. And these conditions are called your adrenal incidentaloma. So your adrenal incidentaloma are masses found during radiologic imaging of the abdomen, and by definition, patients do not present for evaluation of signs and symptoms of adrenal disease. They are only discovered through imaging for other reasons, not because of the adrenal problem. So the incidence is 0.35 to 4.36% in general population using CT scan. So in the evaluation of such mass, so the major concern is to address whether the mass is benign or if the mass is malignant, or does the mass secrete hormones, or is the mass non-functional. So these are the causes of adrenal incidentaloma. It can be non-functioning mass. This is the most common. It can be due to cortical adenoma, myolipoma, cyst, or ganglioma. But for hormone-secreting masses, this can be due to subclinical Cushing syndrome, seen in 6.2%. It can be pheochromocytoma or it can be aldosterone secreting adenoma in 0.89% of cases. So these are the differential diagnoses of adrenal incidentaloma. It can be benign or it can be malignant. So most common are the non-functioning secreting tumors. These are non-functioning adenoma, or it can be lipoma, it can be cyst, it can be ganglioma, or it can be hematoma, or infection. And the most common infection of the adrenal is your TB and fungal infection. So TB is the most common. So hormone secreting, it can be pheochromocytoma, aldosterone secreting adenoma, or subclinical Cushing's. For malignant adrenal incidentaloma, it can be due to adrenocortical carcinoma, or it can be due to metastatic neoplasm, lymphoma, malignant pheochromocytoma. So the presentation. So you need to get a thorough history and physical examination for any signs and symptoms of hormone dysfunction, and this should be completed. So search should include investigation for Cushing syndrome. So what are the clinical manifestations of Cushing syndrome? Weight gain. The patient may have moon fascie, may have supraclavicular fat pads, or deposition of your fat at the back of the neck. This is called your bupaduham. And thin skin. Patient may have easy visibility, and some patients may have proximal muscle weakness. You need also to get signs and symptoms of pheochromocytoma. So the signs and symptoms include hypertension, paroxysms of pain, palpitations, perspiration, or these are the manifestation of pheochromocytoma. For aldosterone secreting adenoma, usually patient is young. In patients with primary or aldosterone secreting adenoma, usually the patient is young, and the patient may present hypertension and persistent hypokalemia. Even if you correct the hypokalemia, it will not be treated. It will only be treated with correction, but once you remove the potassium tablet, the patient will the hypokalemia will recover. So for malignancy, usually patient may have weight loss. This is a known history of malignancy, which makes metastasis to the adrenal gland most likely. So this is the algorithm of how you go about with the diagnosis of incidentally discovered masses. So these are incidentally discovered masses. These are discovered through CT scan. But if you have discovered that the patient is having adrenal mass through CT scan, the patient has no clinical manifestation, then you need to proceed with those screening tests. And so on. So the management. So management, biochemical testing should be done to assess possible hormone secretion. So you need to check the serum potassium, you need to check the plasma aldosterone and plasma renin activity. For pheochromocytoma, you need to check the plasma metanephrines or 24-hour urinary metanephrines and or catecholamines. And for Cushing syndrome, you need to do a 1 milligram dexamethasone suppression. And a disulfide level should also be determined. Then once you have done all these tests for suspected Cushing's or pheochromocytoma or primary hyperaldosteronism, then you need to proceed with radiologic imaging or radiologic assessment. So that first should be biochemical testing, followed by radiologic assessment. So the radiologic assessment would either be CT scan, where CT scan is useful in establishing whether an adrenal mass is benign or malignant by just looking at the size of the mass. So benign if the adrenal mass is less than 4 cm with homogeneous and smooth borders, it is malignant. If the mass in horizon, it is more than 5. If the mass is more than 5 cm, then regardless of the appearance on CT scan, then it is highly suspicious that that mass is malignant. If it is more than 5 in horizon, but in endocrine groups, it is more than 6. So more than 5, it's highly suspicious that the adrenal mass is malignant. So another radiologic assessment is by using MRI scanning. This appears to be specific or as effective as CT scan in distinguishing whether the mass is benign or malignant. Pheochromocytoma, usually they may exhibit hyperintensity on T2 weighted imaging. Lesions more than 6 in size are more likely to be malignant even if they have a benign appearance on MRI. So again, the size of the mass is very important to determine whether the adrenal mass is a benign mass or a malignant adrenal mass. So another test is your fine needle aspiration biopsy. This is not generally advised because this is rarely helpful test. However, biopsy should be done if pheochromocytoma has been ruled out by biochemical screening. So the treatment is surgical removal or adrenalectomy. And follow-up should begin for benign. Follow-up imaging should be done 3 months. After 3 months after surgery, and patients should also be evaluated yearly with a thorough history and PA for the development of overt hypersecretion or malignancy. So what are the key points to remember? Again, as I've said, size is important. Adrenal mass more than 5 or more than 6 cm are more likely to be malignant, and surgical resection should be considered in all masses of the adrenals that is more than 5 cm in size. The great majority of adrenal incidentaloma are benign and non-functioning masses. So we need to have a full biochemical workup, which should be completed before any surgery is done. For pheochromocytoma, we need to require preoperative medical preparation since in pheochromocytoma there is increased levels of catecholamines. Your catecholamines is a potent vasoconstrictor. So in pheochromocytoma, the vascular is constricted, is chronically constricted because of the increased levels of your catecholamines. So you need to prepare these patients before surgery. You need to give an alpha blocker to dilate the venous system, and then followed by a beta blocker during surgery or prior to surgery. Cushing syndrome, this would warrant intraoperative stress dose, steroid, and corticotropin stimulation. So you need to give intraoperative stress dose of your hydrocortisone prior to or during surgery. So for mineralocorticoid excess, this is your primary aldosteronism or your Con syndrome. This is the most common cause of mineralocorticoid excess. This is a syndrome of renin-independent aldosterone overproduction, and this is classically characterized by hypertension, hypokalemia, metabolic alkalosis, secondary to mineralocorticoid excess. The prevalence of primary aldosteronism range from 5 to 12%, higher when patients are pre-selected for hypokalemic hypertension. So what are the screening tests for primary aldosteronism? So the screening test is indicated in individuals with hypertension and hypokalemia, in patients with refractory hypertension. So refractory meaning the patient is already receiving three different class of drugs or antihypertensive medication, but the blood pressure doesn't drop or doesn't go down to a normal level. So in severe hypokalemia, in modest doses of diuretics, in patients with difficulty in maintaining normal kalemia, even with potassium supplements. So you need to screen these patients for primary aldosteronism. So what are the causes? There are 5 types of primary aldosteronism. One is your aldosterone-producing adenoma, or the APAS, which account for approximately 40% of cases. Hyperaldosteronism tends to be more severe with more pronounced hypertension and hypokalemia. So the other type is the idiopathic hyperaldosteronism, or the AIHA. This is due to bilateral adrenal hyperplasia present in 50 to 60% of cases. Patient may possess aldosterone excess in general, but this is milder than your APAS. Another one is your unilateral primary adrenal hyperplasia. This has a similar biochemical features to APAS, but this represents a rare form of hyperaldosteronism. The other subtype is your aldosterone-producing adrenocortical carcinomas. These are rare form of hyperaldosteronism. The 5th one is your familial hyperaldosteronism. It is classified also into type 1 and type 2. The type 1 is called remediable, glucocorticoid remediable aldosteronism. This is inherited as an autosomal dominant trait. The type 2 is also an autosomal dominant inheritance, but it is ACTH independent. The genetic defect in this type is unknown, but it has a similar characteristic to non-familiar causes of primary hyperaldosteronism. So the presentation of patients with primary aldosteronism, hypertension is common, seen in the 4th to 7th decade, except in those with glucocorticoid remediable aldosteronism, in which hypertension can be seen at birth or early childhood. So glucocorticoid remediable aldosteronism. So the clinical hallmark of primary aldosteronism is hypokalemic hypertension. So hypertension plus hypokalemia. So there is slight female preponderance, except in glucocorticoid remediable aldosteronism, in which females and males are equally affected. The clinical presentation are related to hypokalemia, such as patient may have muscle weakness, proximal myopathy, patient may have muscle cramps, and hypokalemic paralysis. Other symptoms are non-specific, such as headache, fatigability, palpitations, and polyuria. There is no specific PE findings in patients with primary hyperaldosteronism. Hypertension may be mild to severe in patients with primary hyperaldosteronism. So there is no typical PE findings in patients with primary hyperaldosteronism. They may present with hypertension and hypokalemia. So that's the hallmark of primary hyperaldosteronism. So again, laboratory findings may include hypokalemia. ABG may show metabolic alkalosis and mild hypernatremia. I won't discuss that anymore. So these are the differential diagnoses of hypertension and hypokalemia. So if you have a patient with primary hyperaldosteronism, or you have suspected that this patient is having secondary hypertension, then you need to get the plasma aldosterone and plasma renin activity. So if the plasma aldosterone is increased, but the plasma renin activity is decreased, then these are the first line is the differential diagnosis. It could be primary aldosteronism, or it can be aldosterone-producing adenoma, or it can be idiopathic hyperaldosteronism, glucocorticoid, or it can be due to adrenocortical carcinoma. So if both the plasma aldosterone and plasma renin concentration and the plasma aldosterone concentration and the plasma renin activity are increased, then these are the differential diagnosis. It can be secondary hyperaldosteronism or aldosteronism. It could be renovascular disease, or it can be renin-secreting tumors. It could be from congestive heart failure or chronic renal disease. If both the plasma aldosterone are decreased and the plasma renin activity is also decreased, then probably your patient is having Brittle disease, chronic licorice ingestion, or the patient may have mineralocorticoid, real mineralocorticoid excess. Those are the differential diagnoses if you have a patient with hypokalemia and hypertension. So you need to get the plasma aldosterone and plasma renin. And you need also to get the plasma renin and plasma aldosterone issue. So these are the screening tests. So screening tests would include your plasma aldosterone, plasma renin ratio. This is commonly used as a screening test. This is reported in nanogram per dl per nanogram per ml per hour. So if the plasma aldosterone concentration and the plasma renin ratio is more than 20 to 50 nanogram per dl, then it is supportive of primary hyperaldosteronism. So the plasma renin or plasma aldosterone and plasma renin ratio is more than 50 or more than 20 to 50 nanogram per ml, then it is supportive of primary hyperaldosteronism. So plasma renin ratio of more than 30 and a plasma aldosterone concentration of more than 20, this has been reported to yield 90% sensitivity and 91% specificity. So another test, another screening test is your captopril test. This is confirmatory for primary hyperaldosteronism. Patients should be standing for an hour. So you let the patient stand for an hour. Then you give captopril at a dose of 25 to 50 milligram tablet of captopril orally after standing. So the interpretation. So plasma aldosterone is normally suppressed by captopril by more than 30% from baseline. In patients with primary hyperaldosteronism, plasma aldosterone remain elevated in spite of the captopril. So your captopril suppresses dapat your aldosterone, plasma aldosterone. But if it doesn't suppress with a dose of 25 to 50 milligram, then you're highly suspicious or highly supportive that this patient is having primary hyperaldosteronism. Kaliuresis, or excretion of potassium to the urine more than 30 milliequivalents in the presence of hypokalemia and a plasma renin activity of less than 1 and plasma aldosterone concentration of more than 30 nanogram per dl and a 24-hour urine aldosterone of more than 15 milligram, this is suggestive of primary hyperaldosteronism. Remember that in primary hyperaldosteronism, the plasma aldosterone concentration is increased, but the level of your plasma renin activity is suppressed. And the plasma aldosterone concentration, ratio, plasma aldosterone and plasma renin ratio should be more than 20 to 50 nanogram per day. So this one is a confirmatory test. So the confirmatory test for primary hyperaldosteronism is not suppression of aldosterone by sodium loading. So you load this patient with a sodium. So a 24-hour urine aldosterone level of more than 10 to 14 microgram after 3 to 5 days of oral sodium loading. You give sodium chloride, you load this patient for 3 to 5 days, and there is no suppression of aldosterone, then this confirms the diagnosis of primary hyperaldosteronism. You measure also the plasma aldosterone levels. This can be measured after 2 liters, or you give 2 liters of sodium chloride infusion given over 4 hours, values more than 10 nanogram would also confirm a diagnosis of primary hyperaldosteronism. So sodium chloride, you can give oral tablet of sodium chloride. If there is no suppression, the aldosterone remain elevated after 5 days of giving sodium chloride, then it is highly suggested that you're dealing with primary hyperaldosteronism. The other is to give sodium chloride or saline infusion, 2 liters, given for a duration of 4 hours. If there is a value of aldosterone more than 10 nanograms per DL, then that would confirm that you are dealing with primary hyperaldosteronism. So the treatment of primary hyperaldosteronism is unilateral adrenalectomy. This is the treatment of choice for both APA and PAH. This is associated with shorter hospital stay and a lower morbidity than an open approach. Adequate blood pressure control and correction of hypokalemia with spironolactone before surgery is also recommended. So you need to give potassium-sparing diuretic in the form of your spironolactone. Your spironolactone is given at a dose of 25 to 50, or you can even give it to around 40 milligrams if there is still persistent hypokalemia. So the medical management would include, this is reserved only for patients with bilateral disease or in patients with APA or PAH who refuse surgery and are poor surgical candidates. So you can give spironolactone. This can be given at a dose of 200 to 400, but in Adrenal, it can be given at a dose of 25 to 50. But in other books, it can be given to 200 to 400 milligrams. So amiloride can also be given, but amiloride has been taken out of the market. It's not available anymore. You can also give triamterene, or for glucocorticoid. This is the condition that is not treated with adrenalectomy. Your glucocorticoid remediable aldosteronism. This can be treated with glucocorticoid at the lowest effective dose. So the treatment for glucocorticoid remediable aldosteronism is glucocorticoid replacement or low-dose glucocorticoid. So what are the key points to remember? So again, symptoms of Crohn's disease, if present, is related to hypokalemia. So these manifestations include muscle weakness and cramping or non-specific symptoms such as headache, fatigability, palpitations, and polyuria. Majority of Crohn's disease have hypertension. Laboratory findings may include persistent hypokalemia. Patients may have metabolic alkalosis on ABG and mild hypernatremia. The plasma aldosterone concentration and plasma renin activity ratio can be used as a screening test for Crohn's disease. And if abnormal, this should be followed up by a confirmatory test by giving by demonstrating non-suppression of aldosterone by sodium loading. Unilateral adrenalectomy is the treatment of choice for APA and PAH. Medical management is only reserved for patients with bilateral disease and patients with APA or PAH who refuse surgery and are poor candidates for surgery. So for Cushing syndrome, this is another condition associated with hormone excess. So this reflects a constellation of clinical features that result from chronic exposure to excess glucocorticoids of any etiology. It is a state of glucocorticoid excess from either endogenous or exogenous causes. So most common for exogenous Cushing syndrome, the most common is iatrogenic Cushing syndrome for exogenous. But for endogenous, the most common is your ECTH producing tumor. Or ECTH secreting pituitary adenoma is the most common cause of endogenous glucocorticoid excess. So remember that. For exogenous, it can be iatrogenic. The most common is iatrogenic. For endogenous, the most common is an ACTH secreting pituitary adrenal. So Cushing's disease is originally described by Harvey Cushing in 1912, resulting from specifically from ACTH secreting pituitary adrenal. So these are the causes of Cushing syndrome. It can be ACTH dependent or ACTH independent. So ACTH dependent Cushing syndrome accounts for about 90% of cases, and your ACTH independent Cushing's accounts for about 10% of cases. So your ACTH dependent Cushing's can be due to Cushing's disease, or it can be due to ectopic ACTH syndrome due to ACTH secretion by the bronchial, pancreatic, carcinoid tumors, small cell cerebellum, medullary thyroid carcinoma, pheochromocytoma, and others. So it can be ectopic, or it can be Cushing's disease from an ACTH producing pituitary adenoma. So the most common is ACTH. Cushing syndrome, Cushing's disease from an ACTH producing adenoma. So again, ACTH dependent Cushing's is the most common, accounting for about 90%, while your ACTH independent accounts for only about 10% of cases. So these are the presentation. The patient may have truncal obesity, facial soreness, diabetes can be seen in patients with Cushing syndrome or glucose intolerance. Patient may have gonadal dysfunction, hirsutism, hypertension, muscle weakness. Some patients may have skin atrophy. They may have easy visibility. Mood disorders, osteoporosis is also seen in patients with Cushing syndrome, edema, polyuria, polydipsia, and they are prone to renal infection. Findings on exam are non-specific, variable and dependent on the presence of and severity of glucocorticoid, mineralocorticoid, and androgen excess. So the patient may have all those clinical features. So differential diagnosis would include pseudo-Cushing syndrome, usually seen in major depressive disorders and alcohol excess. Or it can be due to hypercortisolism without Cushing syndrome, such as in patients with obesity, anorexia nervosa, state of elevated cortisol binding protein, in patients who are pregnant, and in patients with familial generalized glucocorticoid resistance. These are the differential diagnoses. So in the evaluation of Cushing syndrome, this consists of biochemical confirmation and differentiation between ACTH-dependent and ACTH-independent causes. So the diagnostic test would include your 1 milligram dexamethasone suppression. This is the screening test. So a 24-hour urine-free cortisol is the screening test is your 1 milligram dexamethasone, but the diagnostic test would be the most common, or confirmatory test would be your 24-hour urine-free cortisol. So once the diagnosis of Cushing syndrome is confirmed, you need to get the plasma ACTH level. And this should be measured to differentiate whether you're dealing with ACTH-dependent or ACTH-independent causes. So for primary adrenal source, the ACTH level is undetectable if it is adrenal. But for ACTH, for Cushing's or ACTH-dependent causes, such as your ACTH-producing adenoma, the ACTH may be more than 5 to 15 micrograms. Did you get me? So what are the key points to remember in patients with Cushing syndrome? So I did not anymore discuss the algorithm. I just summarize it through that, because sometimes it's hard to follow the algorithm. So what are the key points to remember? The most common cause of Cushing syndrome is a iatrogenic exogenous steroid use. Findings suggestive of Cushing's would include central obesity, striae, hyperpigmentation, skin atrophy, spontaneous ecchymosis, virilization, weight loss, anorexia, proximal myopathy or muscle wasting, and explained osteoporosis and hypothalamic alkalosis. The evaluation of Cushing syndrome consists of biochemical confirmation and differentiation between ECTH-dependent and ECTH-independent causes. You need to get the 24-hour urine free cortisol measurement, and that this is the best test for Cushing syndrome. The best screening test is 1 milligram DEXA, but the best test for Cushing syndrome is your 24-hour urine free cortisol. So the screening test would be 1 milligram, but the best test is your 24-hour urine free cortisol measurement. So plasma ECTH levels would differentiate ECTH dependent from ECTH independent causes. Patients with adrenal adenoma or carcinoma are treated with unilateral adrenalectomy. Transsphenoidal adenomectomy is considered first line in the treatment of patients with Cushing's disease or patients with ECTH producing adenoma. Transsphenoidal. But if it is adrenal adenoma, the treatment would be adrenalectomy. So don't be confused. Cushing's disease, meaning you're dealing with pituitary or hypothalamic tumors. So the best treatment would be transsphenoidal surgery. For ECTH secreting tumors that can be localized by imaging studies should be removed surgically. Occult tumors and metastatic disease may require only medical management. So I think that would be all for adrenal disorders. But I want to proceed with the diseases of the adrenal medulla. Do you have class after this? Sorry. So pheochromocytoma, actually, pheochromocytoma is just a very short topic. Is who will be your instructor?
Dr. Query.
So if Dr. Queen is there, we have to proceed next time. We have to continue this next time. Okay? Thank you so much. I hope I was able to summarize the very long discussion of adrenal disorders in Horizon. Was I able to summarize it for you?
Yes, Doc.
So I hope you did understand when to perform the screening, the diagnostic test, the confirmatory test for such disorder. Okay, thank you so much. I hope you learned from this discussion. Thank you.